And yep, away you go.
Good afternoon, everyone. My name is Thevikum, Nayanajith Edirisinghe, and Master of Medical Physics student at UWA. And my supervisors are Pechman, Milad, Jake, Rohan, Mashid, and Adriano. And my research is impact of planning technique on heart and LED dose, left breast deep inspiration breath hole radiotherapy, and this is a systematic review. Okay. So before getting into the introduction, I will give you some basic statistics I got from the Cancer Australia website. And according to them, it's the second most estimated cancer incident in 2024 in Australia, as we can see in the y-axis number of new cases versus type of cases, and it's almost more than 21,000 in last year. And also from this graph, we can see number of death versus type of cancer, and it is the fifth most common cause death from cancer in 2024 in Australia. And we can see, even though it is the second most incident cancer in Australia, it's become fifth most cause death from cancer. According to this graph, we can see it's reduced to fifth place, and the deaths are around 3,000. So maybe there is some reasons, like there's a big technology development and identifying breast cancers early can diagnosing breast cancers can treat it, and so reduce the number of deaths. Even the incidents are more than 21,000. And also there may be another reason because of the side effects. Because even the treated with the breast cancer with the technologies and early diagnostics, still there is chances radiation exposure to the organ at risk and maybe cause some death because of that. Like for example, heart attack. So it doesn't recorded in here. Okay, so let's go back to the breast cancer with introduction. Breasts are mainly made of lobulous, duct, and fatty and connective tissues. And here in the green color box, we can see invasive breast cancer, and the light blue color ductal carcinoma in situ. I'll explain it a bit in next slide. And we can see if, when we consider the age in 20s from the women, in 1 in 20,000 women get a possibility to get breast cancers. But when they are getting older, like more than 70 age, it's increased to 1 into 25. And it can be, breast cancers can develop both for men and women. And the ratio is 1 man to 100 women. So these are the type of breast cancers that can identify. And if we focus on this image, localized DCIS and invasive cancer, as a DCIS is ductal carcinoma in situ, which is localized to breast, and it grows, but it doesn't spread into the other organs. But invasive cancer is different from the localized cancers because it grows and it spread into blood system, lymphatic system, and it spread to the other organs and cause problems. So next, we are focusing on the breast and lymphatic system, as I explained earlier. Is the first place where the breast cancer can spread, and these lymph nodes are very small rounded glands, and it's protect from the infections. When treating for the breast cancers, especially 3 nodes are considered mostly because they are very close to the breast and make spread to these nodes like armpit. And the second one is the supravascular node, and last one is internal mammary nodes. So according to this Cancer Australia website, it's 1 in 3 women with breast cancers have cancer cells in their lymphatic node in their armpit. Okay, so if you consider organ at risk, mainly lung, heart and substructure like left ventricular descending coronary artery, and spinal cord, esophagus, and ipsilateral brachial plexus, and finally regional nodes are the organ at risk, and that could be effect from the radiation. Next, talk about the cardiac toxicity in left breast cancers. As we can see in this image, the left anterior descending coronary artery is in front of anterior to the heart, and because of that, it's get exposed to radiation easily when treating for the breast cancers. And explain in next slide. So, what are the cardiac induced adverse events? These are few cardiac adverse events, and according to the most famous and like a cited paper of Darby and Hale, it's explained that even for the low doses of radiation exposed to the heart has risk of increasing ischemic heart diseases. So there is no lower limit that can be assigned for this is good for the heart. And also to 16% relative risk of heart disease and major cardiac dose can be increased per K of radiation exposed to the heart. So, left anterior descending coronary artery. As I explained yesterday, why we focus here because it's located to the anterior of the heart, and major coronary events increase linearly with increase with the mean heart doses. Also, there's mortality and mortality, and these are few diseases that can be caused because of the radiation exposed to the LAD. Here, I gave an example of midline tangent treatment and wide tangent treatment for the left and right breast cancer patients. We can clearly see with the when treating for the left and right, this red dot represent the left anterior descending coronary artery, and we can see when you're treating for the left breast cancers is easily radiation exposed to the LAD and heart. But if we go for the right breast cancer, there's a high possibility to avoid the radiation to the left anterior coronary artery. And why we focus on the deep infiltration breath hold technique for the breast cancer patients? The reason is this is deep inspiration breath hold technique is a method that patient take a deep breath around 20 to 30 seconds and until the treatment is done. So what it does, it's increase the distance between heart and the chest wall. So it minimizes the radiation to the healthy tissues and can use it in like treatment like lung cancer and liver cancer and breast cancers. And there's another example of deep inspiration breath holding versus free breathing, normal breathing. And we can see when using the deep inspiration breath hold technique, it increases that distance and reduce the radiation exposed to the heart. So there are some another few importance of deep inspiration breath hold, such as improve tumor targeting, improve patient outcome, safety, maintain good therapeutic index, and reduce radiation to organ at risk. So what are the type of DIBH technique? Importantly, there are few, and I'll talk about many important. First one is active breath controlling. So active breath controlling is a device, as we can see in both these two images. The device is connected to the mouthpiece, and we can see in this image, the bottom image, there's a white color spirometer that measure the lung volume. What is this? When the planning technique, doing the planning technique is defining the predefined lung volume, and when the treatment is started, the clinician asks patient to take a deep breath, and when the deep breath comes to predefined volume, what it is it's automatically close the valve, and when the treatment is started, they know. But we can see in the left corner image that green color window, that's called gated window. So when the lung volume come to that gated window, the treatment is continued. And especially there's a switch given to patient when he feels some uncomfortable, they can like cut off the treatment at any time and treatment is shut down. So it's better for both patient who can voluntary breath holding, or otherwise some patient can't hold their breath voluntarily. So this is a very good technique. And also the second one is voluntary breath hold technique, a good technique that's without using the like ABC devices, is training patient to take breath hold for at least 1 week. So patient holding breath until the treatment is done. The third one is surface guided radiation therapy that use advanced camera patient body surfaces in real time, and this is one of example catalyst SGRT setup in here. So what's the aim here? Aim here is to compare DIBH was free breathing technique, and then as my second aim is to find the optimal treatment method for three scope. First one is whole breast irradiation only treatment, and second one is whole breast with boost irradiation, and third one is whole breast with regional node irradiation. So what is my this is my method I use. As I explained earlier, I did a systematic review and used this database and found 577 papers, and finally included, after screening, included 116 papers, which is huge number of papers. And this systematic review included 6,964 patients data here. So when I screening, considering include and exclude criteria, only use C-arm Linac machines, only use DIBH treatment. And when I mean only DIBH treatment means, when I screening only included deep inspiration breath hold treatment method, and if there is any free breathing technique data available within those papers, I extracted them for comparing the DIBH versus free breathing. And all the photon beams and all the treatment technique and supine position only and left side brace. And if we say why I use this include criteria, the reason is we only considered about the standard treatment method. Like for the example, CyberKnife versus ring Linac. CyberKnife, for the all 570 papers, I didn't find any papers regarding CyberKnife treatment. And there was only one paper conducted breast treatment with the ring Linac treatment. Likewise, only standard B treatment was used. So for the extracting data, I extracted study and patient characteristic data and treatment details, dose to the LAD, dose to the heart, and patient setup as breast holding time, and imaging and planning data was extracted. So when I extracted data, there were like authors mentioned their reported their treatment method in different way. So purpose of summarizing and extracting, I summarized to all these techniques into 6 different techniques like 3D RT, dynamic IMRT, step and shoot IMRT, VMAT, tangential VMAT, and hybrid techniques. So let's focus on the results. Okay, so this graph represents the comparison of mean dose to the left-hand grade descending coronary and a hard by technique, like 2 technique, free breathing and DIBH. Y-axis represents the mean dose in gray, and x-axis represents the radiotherapy technique. And we can see the dark blue color represents the deep inspiration breath hold for left-hand grade descending coronary artery, red color for the free breathing for the LAD, light blue color for DIBH heart, and pink color for the free breathing heart. So, as my first aim, I wanted to compare the free breathing versus DIBH, and we can see this dark blue and red color. We can see it's comparably deep. DIBH technique could reduce doses to the LAD, and when we compare this light blue color and pink color, it can see DIBH reduce the radiation doses to the heart also, rather than using when comparing with the free breathing technique. So if we go for the this dot, why we have dot here? The reason is as a standard, when we plotting the box plot, at least there should be a more than 5 data point to plot a box plot, but these were less than that. That's why it just only represents the data point instead of box plot. And if we go for the each technique, I will explain a little bit here this variation. When comparing with the other technique, 3D CRT technique has lower variation with compared to others, but still we can see there are few outliers and a little bit higher doses, but compare with the other technique, as this dotted green line, we can see the lowest median dose was recorded with the 3D CRT compared with the others, and actually could achieve lower doses like 1.8 gray doses for the LAD. And if we go with the SIMRT technique, step and shoot IMRT technique, the median was around 11.7, and it would achieve the 0.78 gray for the whole breast plus boost treatment. Actually, that was the lowest doses achieved for the LAD from the all the technique, like compared with the others. And but there's still we can see there's variation is a little bit higher. There may be some reason because of only few studies were done with the step and shoot time technique, and few only like 3-4 studies have a little bit higher doses. That's why maybe the variation is a little bit higher. So if you go for the dynamic IMRT with the step and shoot IMRT, dynamic IMRT could deliver like the variation is a little bit lower compared to the step and shoot IMRT, but compared with the data values and dosimetry values, the dose is a little bit higher for dynamic IMRT. And compared with the VMAT technique could achieve lower doses, lower dose variation, and but lower doses variation compared with the IMRT technique. But the thing is, those most of the studies have included the treatment for the whole breast plus regional node treatment. Maybe why one reason is increase little bit higher doses, but there's another reason is because using the long arc treatment instead of using constrained target doses, little bit go high, but it still could lower the variation. And if we consider the tangential VMAT with the VMAT technique, we can see tangential VMAT could achieve lower doses. And if we compare the median dose, as we can see in the 3D CRT technique, the tangential VMAT techniques medians are almost similar, and also it could achieve lower doses like 1.43 gray for the LAD, which was the lowest value for the lower value for the LAD. And if we go for the heart dose comparison, it's similar to like LAD, the variation is lower, like 1.4 gray and 0.61 gray. And why these doses are lower? Because according to the clinicians' limitation, the limit value should be less than 4 gray, and these values compared to the limit is really low value could achieve with this 3D CRT technique. And also, if we go with the VMAT technique, it could the variation will be higher with the 3D CRT technique, as I explained earlier, maybe because of the long arc treatment. And but still, if we go for the tangential VMAT, it could achieve the 0.437. That was the minimum dose that achieves among the old technique for the heart. And the variation is still lower and compared with the VMAT technique. So if we go with the SIMRT technique, we can see the variation is still lower, but compared with the tangential VMAT and the 3D CRT is still a little bit higher doses for reported, but and also if we go with the dynamic IMRT, the doses are higher and compared with this IMRT because the variation is a little bit higher. There's an outliers recorded there. Okay. So next, this is the comparison of mean equivalent dose in 2 gray to left ventricular descending coronary artery and heart by technique. The reason is to plot the equivalent dose 2 gray plot. This is mean equivalent dose versus radiotherapy technique. The reason is to plot this one is clinicians are mostly prefer using the equivalent dose in 2 gray with the physical doses. So that's the reason I plot this one and use the equivalent dose equation as shown in the above. These are some data I extracted for the for my for next final conclusion from the box plot. We can see from the whole breast treatment only with the 3D CRT field and field technique and tangential VMAT technique could achieve lower doses, and for the both LAD and mean heart doses. And if you go with the whole breast with boost treatment, we're using the 3D CRT with field and field technique with SIMR could achieve lower doses. And for the whole breast with regional long treatment, SIMR technique could achieve lower doses like 3.16 and 1.14 mean heart doses. For the recommendation, patients like practice the patient breath holding because it improves the cardiac dose sparing. And next, contrast enhanced CT for LAD. This I need to tell, as I explained earlier, there are some outliers and high doses recorded in some papers. Most of papers recorded as like suggestion. Maybe there's a reason because of they didn't use the contrast enhanced agent to like delineation of LAD. So that's why maybe the accuracy was reduced and doses were higher. So it's better to have contrast enhanced agent for the better accuracy for LAD delineation. Also check and adjust the AI auto counter for both LAD and heart, and secondly check by the radiotherapy for the before treatment. And use modern heterogeneity corrected algorithm for breast plans and applying planning risk volume unsaid, so then can account for the uncertainty and then set up variation. And also checking breast separation distance, and if the patient heart LAD is close to the chest wall, tangential technique would be preferable. As I explained earlier, when considering VMAT, it could use longer that increase the lower bar to the organ at risk. But if you use the tangential like constraints, it could reduce the doses for the organ at risk. And also recommended to knowledge-based planning instead of manual planning technique. And if the large heart or closer distance to the chest wall, it's preferable to have fasting before the CT scan. And separation distance and select the beam energy is appropriate for better coverage. And finally, when using the deep inspiration breath hold, not to arc their back when they do the breath hold intake. This is my conclusion. Out of 274 papers, I included finally 116 papers. And as my first aim, comparison between DIBH was a free breathing. DIBH effectively reduced the doses to LAD and heart. And for the recommendation for the whole breast only treatment, use tangential 3D CRT with field and field technique with the VMAT technique, and for whole breast with boost treatment, tangential 3D CRT with field and field with SIMRD technique, and for the whole breast with regional non treatment, recommended SIMRD technique. And for my future work, I am planning to develop treatment plans by applying current research outcome to see dosimetry for the organ and breast, and doing a systematic review for lung doses with DIBH, because this is really important. When clinician treating for the patients, their first priority is not the heart, is for the lung. So I already have all the data and all the papers, so I can do the extract the data for the lung and conduct the systematic review. And also conduct the treatment planning using the tangential VMAT, because it could really lower the doses for the organ at risk, but still there's a limitation of less number of papers were available in state conduct for the left breast cancer patients. So and as my final future plan is submit my manuscript to Physics in Medicine and Biology journal, hopefully next week, because I already submit my final draft to the authors, and hopefully it's planned to submit it next week. I would like to thank you, my supervisors, and thanks to my peers who support me for whole my period, and thanks to Charlie's department for their resources. And thank you very much for listening.
Well done, perfectly on time.
Yeah.
I have a couple of questions. Maybe I'll just jump in quickly, and then if anyone else has them. So you mentioned that some of the studies involve irradiation of other areas, right? So like nodal areas around there, in addition to local treatment. Did you account for that in your analysis?
Yeah.
And if not, do you think that has implications for?
Are you asking about some papers involving the nodal irradiation, right?
Yeah, so some would have had a lot more dose delivered, I'm guessing, to the area than others. Did you account for that?
Yeah, I count for that. That's why, like, when I doing the extraction for the second name, like, consider some studies have treatment for the, or not only for the breast, have the regional node irradiation. So those doses are comparably higher than the when we some papers mentioning only treatment for the whole breast. Yeah.
Oh, so you did account for it.
Yeah, I count for it.
Whereabouts? Are they on a different box plot or something?
No, that's the main point. Like I was trying to plot them, but the thing is, there's not enough. Like for the considering tangential VMAT, only available like few papers. So if I extracted for the tree score, there's only about 2 to 3 papers may be available for. So it's not practical to plot. That's why as my future, like,
I guess maybe I'm a bit confused then. So the box plot that you presented.
Yeah.
That doesn't include papers which irradiated nodal areas around there.
No,
it doesn't?
Everything is included. Like nodal.
Oh, it does include it.
Yeah, included.
Okay. I guess my question still remains then. You're combining two different things in the box plot, right?
Yeah.
Like some papers are just doing a local treatment.
Yeah.
And others are doing a local plus nodal treatment.
Yes.
Do you think those results are comparable?
Yeah, like for that plot is only first main purpose was to compare the free breathing versus DIBH to plot that box plot graph. And for the scope, I didn't go for the different box plot graph because of the limitation of the papers. So what I've done is like I go through the papers separately and find out the doses, and according to those doses I gave the final result and conclusion.
Yeah, so I get what you mean with the comparison to so DIBH versus free breathing, because they're all the same papers, right?
Yeah.
So you're comparing the same thing, but all of those patients would have had either local or local plus nodal. But I don't think it's I guess correct to compare across techniques that way, because you may have some patients in one of the box plots which have a lot more local plus nodal treatments than the other technique, if that makes sense. So that might, I'm saying that might explain why there are higher doses in one technique than another, as opposed to just the technique itself.
Yeah, I absolutely get what you're saying, but in that plot is only included all as a package, like whole breast plus boost and irradiation, just to compare the free breathing versus DIBH. When we compare the free breathing versus DIBH, it doesn't bother, like it doesn't matter which treatment we treated.
No, I agree. Yeah, I agree.
But for
but I'm saying across techniques.
Technique, yeah. That's good one. Like I talked with the Pechman also about that yesterday also, because I cannot plot these things like separately, is because there's a limited number of papers. Like if I plot like the dot I showed, like I cannot get any result out of that because of the limited. Like for 3D CRT, I can like separate and plot a graph. But if I want to compare with all the technique, it's not like practical for now because of the limitation of papers.
So what we can do just to get a comparison to see for those studies which have just not less growth as well.
Yeah.
So to check if there's any differences.
Mm.
So if there was no just mentioned discussion, there was not much differences.
Yeah.
Yeah, like I think another box plot would be useful, where all you have is papers that are just local treatments, which is probably going to be the majority of them, I'm guessing. And then your comparison across techniques is consistent because they're all local treatments and they're not necessarily going to involve an extra dose to 1, 2, 3 nodes, whatever, around the region. That's what I'm trying to say.
Yeah.
Yeah.
That's right.
All right. Any other questions? Took up most of the time there.
I'll have a quick one, if no one else. Yeah, sort of building on that, because I was wondering, even within, if you have all just local treatments, there'd be different prescribed doses for each treatment, right? So would you also want to control for there being different prescribed doses?
Yeah, absolutely right. Like,
This side in what you already said here.
yeah. Actually, prescribed dose is really important here because treating for the whole breast and regional, like what I found is when extracting, like reading those papers, is the prescription dose is not different. Like even some studies they have done with like different, like comparing VMAT with the IMRT and treating for the whole breast only and also the whole breast regional. And when they doing that, the prescription is constant for all of them.
Oh,
It's like a constant. So they only use one prescription dose for all. Even they use different technique and different. But some papers have like different method. Like some use hyperfractionation, some use standard like for hyperfractionation like 40.4 grain, 15 fraction. But some studies use 50 grain, 25 fractions. That's the thing. Like we need to like for the studies like conduct a treatment plan using technique and using especially because of the time limitation. I extracted data for the angle positioning and countering method, but I didn't include it here because the time limitation. Plan to do the future research. If I'm going to do treatment planning, consider dose, but like prescription dose is really important one, and also like target volume. Those data is still I was extracted, but haven't used because of the time limitation to get a final set. Yeah, that's thank you.
Sounds like a learning. Thanks, Debbie.
Yeah.
Okay. I think that's it. Thanks, Thevikum. Well done.